afternoon, everyone. Today, we are all meeting here to understand more about gestational diabetes mellitus. As we know, it is a very common condition in our obstetric population. So today, we have an excellent talk on prescription writing in hyperglycemia in pregnancy, and we have a eminent speaker, none other than Dr. Pikee Saxena. And for this talk, we have chairpersons with us, Dr. Jyoti Bhaskar, Dr. Raj Bokaria, Dr. Deepshikha Goel, and Dr. Neerja Varshney. I hope everyone is there in the meeting. Dr. Jyoti Bhaskar, ma'am, is current president of East Delhi Gynae Forum East. Ma'am is an additional director consultant of Gynec at Cloud9 Hospital in Delhi and Noida. Ma'am is holding many positions as presently. Is also a co-chairperson of AOGD subcommittee and secretary of Delhi chapter of Indian Menopause Society and executive member of NARCHI and a member representative of RCOG UK. And we have Dr. Raj Bokaria ma'am with us. Ma'am is a senior consultant, Fortis Lafayette and Max Peppergunj Hospital. Ma'am was past president of East Delhi Gynae Forum. She has keen interest in gynae endoscopy, urogynecology, and high-risk pregnancy. And ma'am is currently a chairman of Medical Legal Committee of Delhi Gynae Forum. We have Dr. Deepshikha Goel ma'am with us. Ma'am is senior consultant of gynae, practicing more than 32 years in East Delhi. Ma'am is an executive member of Delhi Gynae Forum East and has many awards to her credit. Most commonly are the Dr. APJ Abdul Kalam Appreciation Award by Delhi Gynae Forum and Appreciation Award from East Delhi IMA and Central Delhi IMA. We have Dr. Neerja Varshney with us. Ma'am is a senior consultant of obstetrics and gynecology and is associated with Cloud9 Hospital, Shantimukund Hospital, Bimla Devi Hospital. Ma'am has keen interest in endoscopy, urogynae, and fetal medicine, and adolescent health expert. Is a certified trainer by Delhi government. Welcome, ma'am. Welcome all the chairpersons. And I request Dr. Jyoti Bhaskar, ma'am, to please invite our speaker, Dr. Pikee Saxena, ma'am, in the meeting. Over to you, ma'am.
Thank you so much, Dr. Meenakshi. I think it is indeed an honor to hear Dr. Pikee Saxena. I would say that in the last few years, when I have heard, she is an authority as far as diabetes is concerned. And she has held several important positions like the governing council member of the DIPSI, executive member of the IFS Delhi Diabetic Forum, ISAR, Endocrinology Committee, FOXI, Safe Motherhood and Reproductive Endocrinology, and I would say that her presence in each and every such committee has a lot of value, and her words and her takeaway from these is something that everyone really looks forward. She's the Director Professor of Obs Gynae at Lady Hardinge Medical College, winner of 31 gold medals and awards for her best research work in national and international conferences. She has edited books, published more than 230 articles and chapters, and more than 250 invited talks. I think it is indeed an honor. And we all have really actually come here to hear you, Dr. Pikee. So to learn so much from you from diabetes, the stage is yours.
Thank you, Dr. Jyoti, for such a nice introduction. And I thank Dr. Shadda Jain ma'am, Dr. Jyoti, and all the other DGF family who have invited me here to share my views. And it is indeed a pleasure to be there with you. And I'm a member of DGF. So I am with my family. And I would want, if you have any queries, if I'm going too fast or too slow, please let me know. And Dr. Jyoti, I'll try to finish in time. So without wasting any time, I would like to share my screen. Is my screen visible, Dr. Jyoti?
Yes, it is visible.
Yes, ma'am, it's visible.
Okay. So I will be talking on prescription writing in hyperglycemia and pregnancy. So how can I remove this thing is coming in the way? No, it's okay. So hyperglycemia in pregnancy is one of the most common medical conditions which we encounter during pregnancy. 1 in 6 live births occur to a woman with some sort of hyperglycemia. Out of 84% are due to GDM. Hyperglycemia, as we all know, is associated with increased maternal and perinatal morbidity and mortality. And besides this, a woman with GDM is prone to get recurrent GDM in 2/3 of the next pregnancies, and she is prone to become a diabetic. 50% of them will develop diabetes within 10 to 20 years. And also, they are going to transmit this disease to the newborn, who is again going to suffer from childhood obesity, impaired glucose tolerance test, develop diabetes and metabolic syndrome at a much earlier age than his mother. So, brief about different terminologies which are very confusing for the average gynecologist and even for the PGs and faculty in my institute. Now we refer to diabetes in pregnancy as hyperglycemia in pregnancy. I will take sorry, what have I done? I wanted to take a pointer. Just a second. So hyperglycemia in pregnancy can be divided into diabetes in pregnancy and GDM. So diabetes in pregnancy is the same as pre-gestational diabetes or overt diabetes, and it may be type 1 or type 2. So don't get confused. Hyperglycemia in pregnancy could be diabetes in pregnancy, pre-gestational diabetes and overt diabetes. It could be type 1 or type 2. It may be diagnosed before the start of pregnancy or may be diagnosed for the first time during pregnancy. So what is the definition of diabetes in pregnancy? That is the standard WHO definition, where a male or a female is diagnosed as diabetes if the plasma glucose level in the fasting state is more than equal to 126, random or 2-hour post glucose, or HbA1c is more than 6.5%. If any time during pregnancy, before pregnancy, during labor, post delivery, if the thresholds cross 126 fasting or postprandial more than 200, then you can easily label her as overt diabetes, as we used to call her. And GDM is threshold between 140 to 199. So this is a very important concept because GDM is mild insulin resistance and it may get controlled with MNT. 85% of the women will get controlled with MNT, medical nutrition therapy, while when we are dealing with overt diabetes or pre-gestational diabetes or diabetes in pregnancy, we need to be aware that it is a severe insulin resistance and we have to take action very quickly. So if we know that a woman is suffering from diabetes and she comes to us in the infertility clinic or she's coming to us in the to a physician, then what all things we need to do? So preconceptional prescription will include education, not only of the mother but also of the family, especially including the husband and the mother-in-law. She has to be told about the risks to the mother and to the fetus, the diet that she has to take, exercise, which is very important, signs and symptoms of hypoglycemia, how she needs to use the glucometer, and why self-monitoring of plasma glucose is the mainstay. Need for multidisciplinary team approach because she has to be in concurrence with us, with a physician or an endocrinologist, a nutritionist, and also a physical educator. We have to tell her some targets. Before she conceives, her HbA1c should be less than 6.5, so that the risk of congenital anomalies is as close to normal pregnancies as possible. And before reaching this goal, she should not conceive and she should use contraception till then. Her BMI should be optimized to less than 23. Blood pressure target should be less than 130/80 in hyperglycemia in pregnancy. And she should discontinue any oral hypoglycemic agents, any ACE inhibitors or ARBs she's using for control of BP, statins and fibrates, which are contraindicated in pregnancy. So she has to be switched on to labetalol or alpha-methyl dopa or nifedipine. She should also undergo a retinal assessment, renal assessment, thyroid function test, because 5 to 10% of these are associated with thyroid of diabetics, also have thyroid dysfunction. She should also be evaluated for neuropathy. It is a long duration of diabetes, and her foot should also be examined. Along with this, we need to give her a folic acid supplementation of 4 milligram per day. So, as the Indian woman, if she's a known diabetic, we are going to do and take all these precautions so that in the periconceptional period, her glucose levels are normalized. If she is not a known diabetic, then as Indian women are more than 11 times more prone to develop diabetes during pregnancy, because our insulin resistance is very high, a universal screen is recommended at the first visit as soon as her UPT becomes positive, and she has to undergo a DIPSI test, which is recommended by the Ministry of Health and Family Welfare, where a 75 gram glucose is given in 1 glass of water. She drinks it within 10 minutes, and 2 hours later, if her plasma glucose comes as more than 140, then she is labeled as a GDM patient. Even if she comes negative at this time, she should undergo this screening at 24 to 28 weeks and similarly label her as GDM. And this is, again, it could be a point of care test. In the periphery, or if you are sitting in your own clinic, you can use a AccuCheck glucometer, and the sensitivity of AccuCheck glucometer and the venous plasma glucose has been found to be very accurate and is evidence-based. So the scientific validity, the international bodies always doubt the scientific validity of Indian things. So Made in India is the logo given by our Prime Minister, and Dr. Seshayya had put in this DIPSI criteria, which is very, very feasible and practical for our setup. There are so many studies where the evidence has proved that DIPSI has very good diagnostic accuracy. We have compared it with WHO GTT, Carpenter-Houston, and NDDG, and HbA1c, where we found the sensitivity to be more than 98%. So when to start any treatment, what are the threshold or target plasma glucose levels? If the fasting or pre-meal plasma glucose, it should be less than 95. 1 hour post-meal, which is not to be done at all, should be, if suppose the patient comes and somebody has done it at 1 hour, it should be less than 140 milligram per deciliter. 2 hour post-meal should be less than 120. HbA1c, if you are doing, it should be less than 6, which is going to be very good. But if she is a chronic diabetes, even getting it less than 6.5 is good enough, as recommended by ADA. During labor, it should be between 70 to 120 milligram per deciliter. And at night, 2 or 3 a.m., to distinguish between the dawn phenomena and the Somogyi phenomena, the threshold should be more than 70 milligram per deciliter. So if we do all these 7 points, and if the target plasma glucose levels are exceeded, we advise lifestyle change, including the medical nutrition therapy and exercise. What does our DIPSI guideline? The DIPSI guideline was again amended in 2021, and according to DIPSI, the fasting should be less than 90. Postprandial is same as the international bodies, less than 120, and mean plasma glucose should be 105 or less. So in very short, although this is the sheet anchor of the treatment of GDM, medical nutrition therapy is extremely important. Goals are optimal nutrition for the mother and the baby without having ketosis on one end and hypoglycemia on the other. The weight gain and calorie need needs to be predetermined according to the pre-pregnancy weight. Carbohydrate quantity, quality, portion size, glycemic index, and distribution along the day has to be properly planned, and not just carbohydrates. We need to give adequate attention to protein, fat, and micronutrient distribution. So if we take our 3 major meals, just see what is happening. There is a big peak and then a trough. So this gives rise to very high glycemic variation. And now the new concept is that this high glycemic variation leads to oxidative stress and is responsible for maximum injury to the mother and the fetus. So if we distribute in slightly smaller 3 meals along with 3 snacks, just see the average are going to be normal. So this is what is advocated. And in a busy OPD, I think the government of India Thali concept, which I think everyone knows, should be followed and prescribed. Exercise is another very important component because it increases the insulin sensitivity, keeps the muscles in tone, and also utilizes the calories so that the glycemic level comes down. At least 30 minutes of moderate intensity aerobic exercise walking, breathing exercise, upper limb, lower limb exercise, at least 5 days a week or minimum of 150 minutes per week is recommended. Even 10 to 15 minutes walk after every meal will bring down improve the insulin resistance. So when should we, till how long should we continue medical nutrition therapy? If the diet and exercise fail to achieve blood glucose targets within 2 weeks in the second trimester or 1 week during third trimester, or if it is detected, if diabetes hyperglycemia is detected in the first trimester, you immediately start pharmacotherapy because there is already damage which is done and we need to bring it down at a faster pace. So in the pharmacotherapy, again the question comes, should we give insulin, or how safe or how effective are the anti-diabetic agents and what are the choices? So some of the indications for starting insulin therapy for women with GDM where metformin or glyburide will not work is overt diabetes, fasting plasma glucose more than 110, 1 hour glucose more than 140. If the period of gestation is less than 20 weeks or if it is more than 30 weeks, if the lady has macrosomia or FGR, even FGR, please note, that means that the metabolic alterations are severe. So we need to immediately start her on insulin rather than going for metformin, as we will be discussing in further in the lecture. During labor, for strict glycemic control, if the diabetes is associated with any organ dysfunction, be it retina, kidney, cardiovascular problems, if she has ketoacidosis, medical complications, or if we are giving her steroids for fetal lung maturity. In all these conditions, we need to give insulin, which is the only therapy. So a bit basic about insulins. We have basal insulin and we have bolus insulin. So basal insulin is going to control or suppress the hepatic glucose production, and it is going to keep normoglycemia during fasting state and pre-meal state. And for this, they recommend the intermediate acting or the NPH insulin or the long acting insulins, which are Detamir or Glargine. The bolus insulin is the insulin which will take care of the exertions of glucose after we take any food. And for this, we have short acting insulin, that is regular insulin, or rapid insulins, which are Aspart and Lispro. So regarding the safety and level of evidence, now the WHO category of ABC has been removed, but Lispro, Aspart, regular insulin, NPH and Detamir are category B and have found to be safe during pregnancy. So what happens to insulin requirement in diabetes in pregnancy or overt diabetes? So in type 1, we can start approximately at 0.7 units in the first trimester, 0.8 in the second trimester, 0.9 in the early third trimester, and after 35 weeks, 1 unit per kg. This will vary from patient to patient. You must have seen in your clinical practice. The sensitivity to insulin differs depending on the BMI, on the insulin resistance, on hirsutism, hyperandrogenism, comorbidities associated. So each patient is going to respond differently to the same amount of insulin. For type 2 diabetes, insulin requirement during first trimester is same as the pregnancy levels, but during the second half, when the placenta is secreting maximum amount of glucogenic proteins, then the insulin requirement will increase disproportionately because of increased insulin resistance. This is a very important slide. I think we need to just focus on the time of action, and Lispro and Aspart these two are the rapid insulins. So we tell the woman to take it at the start of meal. The onset of action will start within 15 minutes and peak is at 1 to 2 hours. So in the physiological normal pregnancy, the peak is at 1 to 1.5 hours. So these insulins will take care of this peak and the action will last only for 4 to 5 hours. This is the rapid insulin. The action is going to last for 4 to 5 hours, and by this time the postprandial peak and the also is over. So chances of hypoglycemia are less. Whereas our normal regular insulin, we have to advise the patient to take it half an hour or 1 hour before the meal. The peak action will come at about 2 to 4 hours, but the problem is that action will last for 8 hours. So between 4 to 8 hours, she is prone to hypoglycemia. Then comes the NPH insulin or the intermediate insulin. The action will start at 1 to 3 hours. Peak will come at 5 to 7, and then it is going to last for 13 to 18 hours. So at this time, she's prone to get hypoglycemia. Then we have the detamir insulin, which is safe in pregnancy. So this is the basal insulin, and it has a very small peak, and the action is going to last for 18 to 26, but it still has a peak. But the latest is the insulin glargine, which is a long acting, and as you can see, it has no peak, so no chances of hypoglycemia, and the action is going to last for 24 hours. So we have given her medical nutrition therapy, but the target levels are not met. So now what to do? We have to admit the patient, do a 7-point profile, fasting, pre-meal, 2 hours post each meal, and then at 3 a.m. These levels are done. Insulin may be started as approximately, this is not exact, 1 unit for every 20 to 30 milligram glucose rise. So if fasting is high, we have to give NPH or long, this is intermediate acting or long acting insulin at bedtime. If post meal, that is, if she is having postprandial hyperglycemia, which is the hallmark, which is the main problem in GDM, then post breakfast, post lunch, or post dinner, if any of these is high, then we have to give a short acting insulin, or we can give rapid insulin. Okay? So that is the funda. If pre-lunch or pre-dinner is high, then NPH or regular insulin, this is going to act for about 12 to 18 hours, and this is going to act for 8 hours. So it will take care of the next meal. So it has to be given the previous meal, before breakfast or before lunch. The other thing is, if pre-prandial levels are raised, add morning NPH also. If fasting is high, then we have already added NPH in the night. In GDM, basically, the requirement of insulin, because it is a mild condition, is roughly half of pre-gestational diabetes. And if someday, we find that the insulin requirement has suddenly become high, we should look for all these things: stress, sepsis, steroids, obesity, advancing pregnancy. These increase the insulin requirement. So this is the same thing. I will not read it again. So basically, we calculate these small doses of insulin and calculate the total requirement over 1 day and divide it into pre-mixed insulin, which is recommended in our Government of India guidelines. This is given before breakfast and before dinner. Two-third of the total dose is given in the morning, 1/3 in the night, and out of this, 2/3 NPH and 1/3 small-acting regular insulin in the morning, and 50% of these in the night. So it has been seen that the rapidly acting bolus analog may be preferred over regular insulin because hypoglycemia is not there, although perinatal outcome with both is better. Multiple injections, if feasible, have a better control as compared to the pre-mixed insulin, which is recommended for most of the periphery and places where the facility is not available. So this small example, 27-year-old lady comes to us. First visit, we order a Dipsy and it comes out to be 148. We admit the patient, do a SMBG, and we find that her after lunch is high, about 35, and after dinner is high. At this time, the level should be 120. So 155 minus 120. So we find that 30 milligram raise is there. So along with MNT, she is already third trimester. So you start MNT along with this 1 week trial you can give if growth of the baby is fine. And you can add 2 units of regular insulin or rapid acting insulin before lunch and 2 units before dinner, which will take care of this. In another patient, she is coming to us in first trimester. Dipsy comes out to be 191, which is quite high. And also she is 12 weeks. So she may be pre-gestational diabetes. We do a SMBG and a 7-point profile, and we find that before breakfast is deranged and after dinner is deranged. So along with MNT, before dinner, we can add 2 units, And for controlling before breakfast, we can again add 2 units of NPH, because this should be 90, 122 minus 90, so it is going to be about 40-50 rise. So that way you can titrate. This chart, again, the government of India says that you have to do a 2-hour postprandial glucose. If it comes above 100, and this is the minimum requirement which should be done. So if it comes more than 120, you have to start pre-mix insulin, 30-70 ratio, half an hour before meals. And this is the threshold, 120 to 160, 4 units, 160 to 200, 6 units. And government of India says if any time more than 200, start 8 units. And then after third day, you again measure the fasting and postprandial glucose. If it is less than 120, you can continue and then monitor it after some time. Treatment of hypoglycemia, it is defined as less than 70 milligram, and the family and the patient both should be made to understand the signs and symptoms. And the treatment is 3 teaspoonful of glucose powder, which should be always available with the diabetic patient in a glass of water. Rest for 15 minutes, then eat something. If glucose is not available, 6 teaspoons sugar full of sugar in water, or juice or honey or any other thing can be taken. Once the plasma glucose levels are controlled, do we still need to monitor 7 times? That is generally not feasible. So our government of India says that once controlled, monitor every third day, only with fasting plasma glucose and 2 hours, and metformin bi-weekly by fasting and 2 hour post meal. But I think this is for the majority of the country where the facilities are not optimal. And we are generally following the international criteria. So where we do a fasting and we do post breakfast one day, post lunch one day, and post dinner another day, and 2 a.m. So 2-3 samples can be taken in a staggering approach, at least 2 to 3 times depending on her control. And also another important point is that fasting and PP should be checked once in a week, corroborate, so that we can corroborate our glucometer with the lab values. Must remember the postprandial is the hallmark, and this is more associated with macrosomia. Antenatal visit should be done as high-risk pregnancy every 2 weeks, and she should report with blood sugar profile. If the target is exceeded, she has to come to us earlier. Oral anti-diabetic agents, only glyburide and metformin are category B, but just note that both of them are crossing the placenta. So many times this question is there in our mind. If the patient has conceived on metformin, should we continue metformin? So this is a big meta-analysis which says that metformin treatment in women with PCOS throughout pregnancy would increase the possibility of term pregnancy, vaginal delivery, reduce early pregnancy loss, preterm delivery, complications like GDM and PIH with no serious side effects. Moreover, it was not associated with any teratogenic problems, so they recommend that it should be continued throughout pregnancy and is safe for mother and fetus. But the American Diabetes Association 2022 says metformin should not be continued in PCOS patient after conception. But in India, where if the woman is not ready to take insulin as the first choice, or she is not able to, she lives in a periphery, she is not able to monitor, and she is willing to take oral anti-diabetic agent, we can prescribe that, because the most fundamental thing in managing hyperglycemia in pregnancy is to achieve normoglycemia. So it is more convenient, less expensive, less monitoring is required. If preferred by patient, it will increase to treatment adherence. It is especially useful for women who are already obese or who are already on high doses of insulin, because this improves the insulin sensitivity and will bring down the demand of insulin. It reduces weight gain during pregnancy and lowers the chances of hypoglycemia. So this is the metformin. The main problems are that it causes GI disturbance. So a sustained release should be used, and tell her to take it with meals starting at night, and 500 is the initial dose, and you can titrate every weekly and increase it to a maximum of 2000. The advantages are that it is not going to cause any hypoglycemia. There is reduction in weight gain and macrosomia. Small dose, as we discussed, added with high dose of insulin will reduce requirement of insulin, and it is secreted in very negligible amount in breastfeeding, so it is considered to be safe during breastfeeding. But the problem is, the concerns are that nearly 30 to 50% of the women are not going to be controlled only on metformin, and you will anyway have to add insulin. The chances of preterm labor, which is a big killer for the babies, is 1.5 to 1.7 times higher. It causes B12 deficiency, and the other big problem is that it crosses the placenta, and long-term effect on offspring is not. However, it should not be used in women with preeclampsia or at high risk of FGR because it causes fetal growth restriction or acidosis in the setting of placental insufficiency. Glyburide, the dose is 2.5 milligram per day to 20. It is not used or prescribed very frequently because it has a high chance of macrosomia and 2 times higher chances of hypoglycemia in the baby. And approximately 16% patients will not get controlled, and anyway you will have to add insulin. So what is the evidence till date? The ministry, the Indian guidelines and the NICE 2015 recommend, all guidelines recommend insulin as the first choice, but Indian guidelines recommend metformin also as the first choice, as to the NICE guidelines. The earlier guidelines did not recommend metformin to be used in pregnancy, while the newer guidelines 21 say that it may be used in pregnancy. Australian guidelines do not recommend its use. ACOG and ADA give a guarded this thing, and they say metformin, insulin should be given to all patients, but if the patient refuses to take insulin, then metformin may be used as second line for those who deny insulin, and they should be counseled and take a written informed consent, because litigations have also been done on these pretexts, because long-term safety is not established, enough evidence is not established as it crosses the placental barrier. Another very, very important points, these are just guidelines, but what do the regulatory or law-holding bodies say? The US FDA, Australian regulatory body, and the Drug Controller General of India do not approve metformin for use in pregnancy. Package insert of metformin says that they should not be used during pregnancy unless clearly indicated, and they are not safe to be used in children below 10 to 16 years. Garima, ek baar call dekh lo. This is a very, very important paper which I could find, that this is published in the American Journal of Obs and Gynae 2018, a cautionary response to SMFM statement. They had earlier said that metformin can be used in pregnancy, but now they say that we should give a pause to the widespread adoption of metformin during use in pregnancy, because the concentration of metformin in fetus is very high, and metformin can cause inhibit the growth of the fetus, inhibit or suppress mitochondrial respiration, have epigenetic modification on gene expression, epigenetic changes can occur, mimic fetal nutrition restriction, and alter postnatal glucogenic responses. It has a direct effect on fetal programming and has adverse long-term outcome on body weight and metabolism, and also produces metabolic phenotype that increases childhood weight and on weight and obesity. So this is a very, very important paper. Then again, questions our widespread use of metformin. This is another paper I could find. This is a very important paper again, BMJ Open Diabetes Research Care. This was published in 2022. It is a register-based cohort which included a large number of patients, 3,967 on metformin, insulin, 5,000 patients, and combination of metformin and insulin, 889 patients. And they found that significantly increased risk of being small for gestational age associated with exposure to metformin compared with insulin, which suggests caution in pregnancies with at-risk fetal undernutrition. However, another on the other side. On 28th of February 2022, the European Union have given clearance to glucophage based on the work done by Merck's own safety cohort study, CLUE study, and they have recommended that it may be used, and it has a significant unmet medical need as the prevalence of hyperglycemia during pregnancy is increasing widely. So, whenever you are using metformin in pregnancy, first give the choice of insulin. If the woman is not ready to use, take a written informed consent, explaining to them that this will pass through the placenta and long-term scientific evidence of good strength is not available. Another very debatable important question is use of antenatal corticosteroids in late preterm. Before 34 weeks, there is no controversy. We can give steroids for lung maturity. But this is SMFM series 58, which says, this is published in 2021. They recommend against the use of late preterm corticosteroids in pregnant women because there is a risk of worsening of neonatal hypoglycemia. But they also recommend that patients at risk of late preterm delivery be thoroughly counseled regarding the potential risks and benefits, because they found that it reduces neonatal respiratory problems to quite a great extent. So patient and her relatives should be counseled, told about the pros and cons, and also should be told that the long-term risk remains uncertain. But the next year, 2022, and this is just July 2022, recommendations of the RCOG, the Green Top Guideline 74, very, very important. They say that diabetes should not be considered as absolute contraindication to antenatal steroids, totally contradictory for fetal lung maturity. In women with diabetes who are receiving corticosteroids, add additional insulin. So whenever we are giving dexamethasone for lung maturity, we need to admit the patient. The glucose levels will start rising within 12 hours and will stay higher till 5 hours. And we have to do SMBG 4 hourly and add additional insulin about 20 to 40% as what she was taking before this, and prevent any diabetic ketoacidosis. And what they say is for women with diabetes undergoing planned cesarean section between 37 to 38 weeks, informed decision should take with the woman and her family, whole family, about the potential risks and benefits of corticosteroids. I'm not going to discuss the fetal monitoring. After this, the glucose levels need to be monitored, fasting and PP for 1 to 3 days. In GDM, as soon as the placenta is out, the requirement of insulin will come down. If she's on diet or she's on metformin, she will not be most probably needing any more anti-glucogenic therapy. Insulin requirement will also come down. For type 2 diabetes, they can be switched over to pre-pregnancy dose of metformin or glyburide. For overt diabetes who were on insulin, the dose may be reduced by 20 to 40% depending on the SMBG levels. Another thing is for breastfeeding, first line is insulin, but metformin and glyburide are also secreted in negligible amount and have been found to be quite safe. Postpartum prescription is very important according to MOHFW. She has to be called, and this is very, very most important part, because we have to call them at 6 to 12 weeks, give them a 75 gram oral GTT load. This is not the same as Dipsy. We have to call her in the fasting stage, give her 75 gram glucose challenge, and do a post glucose test. If it comes more than 140 till 199, this is impaired glucose, and if it is more than 200, she is a diabetic. And this has to be repeated every year. If it comes normal, then please call her next time and take this opportunity to measure her hemoglobin level, blood pressure, waist hip ratio, BMI. Breastfeeding should be advocated for more than 3 months, because this will delay the time of initiation of getting a diabetes up to 12.3 years as compared to 2.3 years. It brings down the glycemic, the glucose levels, brings down the calories, and of course the benefit to the baby is also there. Counsel her for next pregnancy after preconceptional counseling. Contraception. For contraception, any contraceptive method is safe for a woman with GDM. But if the woman has type 2 diabetes, or if the duration is more than 20 years, then we have to avoid estrogen containing OCs or contraceptives, and injection DMPA is also category 3 and 4. IUCD barrier are category 1, rest all are category 2. So to conclude, maintaining euglycemia with supervised multidisciplinary care will avoid short-term and long-term complications, both for the mother and the fetus. Early diagnosis, patient education, lifestyle management with medical nutrition therapy and exercise forms the backbone of treatment, and nearly 85% women will get controlled only on this. Insulin is the gold standard for treatment of diabetes in pregnancy with unparalleled and unquestionable efficacy and safety. No oral agent is FDA approved, and this use in pregnancy is off-label. Metformin should be a second-line approach. Counsel the woman about increased risk of preterm birth, 26 to 46% failure rate, placental transfer of the drug, and lack of long-term data in exposed offspring. Please write it down in their prescription to save any medico-legal problems. So I thank you all for a very patient hearing. And
Thank you, Dr. Pikee, for an excellent deliberation, and all our concepts are now quite clear how to write a prescription in a patient with GDM. So hats off to you for this excellent presentation. I will invite comments from the chairpersons. Dr. Deepshikha ma'am. Ma'am, you are muted. Please unmute yourself first.
Thank you, Dr. Pikee, for such an extensive and very comprised. Every point was so clear that we could, I think there's nothing to add. I just wanted to say that she has elaborated all indications for insulin therapy, and it is the first line of therapy we should advocate. But there are few absolute indications, like she has enumerated many, but I can add one or two. Like if patient has suddenly developed hydrangeos, or she is going for macrosomia or IUGR, or complicated diabetic like ketonuria or other complications, renal or hepatic. So that is absolute indication for insulin therapy.
yes, planned surgery also. I
Ma'am.
that in my slide, but I think it was. I think it's a very important point.
Yeah.
Residents generally think that macrosomia is there, fasting PP is controlled, so we don't need to add insulin. But at that time, I would say that you do a 7 point, and if even a little rise is there above the target, please add insulin, because that means that a significant metabolic alteration is already there. Very important point.
Any comment about continuous glucose monitoring, those sensors we are getting these days?
So I
range is sugar target in range and percentage.
Yeah, Dr. Vanna, it's a very, very useful tool. I have used it in 2 theses of mine, and what I found that it picks up nocturnal hypoglycemia to a great extent. In our study, we found that it was occurring in nearly all patients, and up to 60% of the 60 to 70% of women were having nocturnal hypoglycemia. So you can tell them to take a bit or a small snack before sleep. Another thing is that it gives a very good patient education tool. Usne kela khaya, and after that you see very nicely on the graph that glucose levels are increasing. She's taken khichdi and it had less of dal and more of rice. You see a significant increase. So patient ko follow up ki diary maintain kare and use. This is not very costly, about 2,000 rupees for 14. And it measures interstitial glucose as compared to the capillary glucose we are measuring. Or इसमें जो है the blood glucose levels give a delay lag of 15 minutes as compared to the capillary glucose, and the levels are also a little lower. But it is a very, very good tool for type 1 and for patient education. and for picking up nocturnal hypoglycemia, which we cannot do. It is not feasible. The patient will get so much stress, her glucose levels are going to increase. So it is very, very useful.
We have two questions in the chat box. We have
doing dipping in correct way is also very important, Pikee. I think how the patient has to take it within 15 or 20 minutes. She should not vomit after that, and then she should not run around. She has to sit patiently at a place and get 2 hours PP done. Dr. Pikee, I just wanted to ask. Yes.
Not drink anything after that, and sister should note down the time when she's giving glucose, and again do it exactly after 2 hours. Sometimes they come with very high values, and we find out that sister has done it after 1 hour or 1.5 hours. That will give a false. Yes, doctor.
At times, Lal lab people are giving 100 grams. Those boys working,
that is, we have to ensure. So you can do it even in your lab with a good glucometer, and that has to be corroborated with the venous values after every 20 readings. Or now very good glucometers have come. You can do 1,000 readings before getting any calibration done. This is known as glucometer facility. So I think in our hospitals, we should be using that, because we have a Dipsy station where all women who are coming undergo this test, and then only we take them.
Then they all sit for 2 hours.
Madam, what we do is, जैसे ही वो अंदर आ रही है ना, उसका हम डोज दे देते हैं. And then she undergoes BP, urine, examination by us, and tetanus. By the time it is already 2. So she doesn't have to wait for too long. So just at the entry, when she's entering the antenatal clinic, we have this station. So that is why time is not wasted. और उस समय, as it is a point of care test, we can catch the woman, tell her कि ये problems बच्चे को हो सकती है, and they are very, very sensitive at this time, and we can start the intervention right there and.
You can use 2 hours for showing them some educational videos regarding nutrition.
Very, very good idea. That is being done. That is what is recommended by the guide.
Pikee, I just wanted to know that you highlighted the importance of 7-point testing. So in guidelines of Government of India, they say that you do Dipsy, and if it is more than 140, you can directly give MNT for 15 days and then get PP 2 hours done. So I'm afraid these 7 points are not mentioned in the guidelines. So what is your opinion? What should be the ideal way?
70% of the population is staying in the periphery, in the rural areas. This is the basic that should be done. But what I've seen is that sometimes fasting and PP is normal, but her post-dinner or post-lunch becomes very high. So unnecessarily you will be delaying treatment. So if possible, you can do 4. And these women, even in our government hospital, they are very, very sensitive. You teach them and they will do a 7-point. Copy पे we write down कितनी बार करना है, या we give them a printed paper. And they really do it religiously, most of them. So if you have the facility, if the patient is ready to take it, why not take the opportunity? Because you may miss. And Government of India, it gives minimum requirements. And so that it can be followed at maximum number of visits. So that is, I think, my take.
I think we can take a few questions from the chat box. This is regarding the first trimester screening. Can blood sugar fast? Yes, ma'am.
And actually, we have got
We just take a couple.
other chairpersons also have to.
I thought we will take the questions first and the chairperson's comments.
I think you take the chairpersons.
Okay, ma'am. Dr. Neerja, ma'am, you want to say something?
Yeah, I want to ask, do we regularly do HbA1c like monthly, or how frequently we have to do that along with the monitoring we are doing otherwise?
Madam, very good question, because our physician friends are monitoring pregnancy, diabetes with HbA1c, so they generally recommend HbA1c. So we need to remember here that it gives a 3-month control, and it does not give an instant blood glucose values which have to be corroborated in pregnancy, so that we can take timely action. Another thing is that the RBC turnover is very fast during pregnancy, and most of our women are having anemia, so it gives a lower value. And the third most important point is, even in Delhi, only 2 centers have the accredited lab. It has to be done by HPLC method. It is not available in majority of the country. So even WHO says that pregnancy we need not do HbA1c. It is definitely useful in the first trimester because it will distinguish between pre-gestational diabetes and GDM, and also it will give us some idea about the prognosis of congenital anomalies. Because as the HbA1c increases above 6.5, the risk of congenital anomalies is high, and after 10 it becomes 25%. And even in our study we have proven that when you compare its sensitivity or diagnostic accuracy with OGTT, it is only 68 to 70. And in pregnancy, as you rightly said, Dr. Neerja, it has to be done every month. So it is no point. We cannot monitor. It just gives us some idea about this, but of course it is useful in the first time.
And how frequently we should do CGM?
Pardon?
How frequently we should do CGM, continuous glucose monitoring?
CGM, as I said, you get a graph for 14 days. So actually it is enough to teach the patient. If required, you can do it 3 times, because as the period of gestation increases, the glucogenic hormones will increase and the requirement of insulin will also increase. So it gives you a rough idea. You can use it as a tool, and depending on the patient's paying capacity, you can use it more frequently. It is especially useful for women with type 1, because what I see is ekdam upar jata hai and ekdam niche aata hai. Their levels are fluctuating quite a lot. So the evidence says that it has more role to be used in type 1, whereas it can be, now it is recommended for even non-diabetic patients, non-pregnant, non-diabetic patients. So I think all of us should get it done. It really teaches us when kya nahi khana, kab nahi khana, kya karna hai. So that way it is a very good. And always remember that it will give a lag of 15 minutes, because that is capillary, and what we are measuring is interstitial glucose. And also it will be a little lower because the tissues have already utilized that glucose. So the level in the interstitial glucose is going to be lower than the capillary. Sensor is about 5,000, 6,000 rupees, and generally the patients don't buy it, but it is available for the physicians to buy it. Once you buy it, you can use it lifelong. So it is not that expensive. Buying glucose sticks, glucometer is also quite expensive. So this can be used. I think it's a very useful tool. That's what I found in my patients.
Okay. Dr. Jyoti ma'am?
No, I think you asked Dipti and the other chairpersons.
Dr. Jyoti ma'am, you're the chairperson comments, ma'am.
Yeah, Dr. Batra, all labs are doing HbA1c.
Is not there, I think.
Even our lab is doing HbA1c, but the values are not correct. It is to be done by a method which is recommended by WHO and the lab manuals, which is not being followed. So there is arbitrary method which they are using, and the values are absolutely different. And you cannot base your treatment on that, especially during pregnancy, because this is a very crucial time and we want immediate control. Because as we know, the pancreas developed by 6 weeks, and the insulin is 8 to 11 weeks, and the epigenetic changes will occur by 11 to 12 weeks. So if we don't take action immediately, the epigenetic changes and the transmission to the baby would have already occurred.
So I think we're going to take on the questions if there are any left, or are we going to take questions after the panel discussion?
Abbott is and Free Libre is the name of the continuous glucose monitoring for ambulatory glucose profile.
Jyoti, can I ask one question if you allow me?
Yeah.
What insulins are available in your government hospital? Means what should we make available in our pharmacies and in a government setup? Yes.
Very pertinent question. We have only regular insulin, premix insulin, and NPH. Dr. Jyoti, madam, what do you have in your private setup? And most of our doctors or the CGHS panel prefer to use Lispro or Aspart. So only in those patients I have experience of using rapid, and most of our major patients are using NPH or regular.
Thank you.
Okay. Before we go on to panel, I think we can have one question. And I just want to ask regarding the patients who are PCOS patients who are already on metformin, regarding how to screen them for gestational diabetes.
So if they are already on metformin, what we can do is that we can do a fasting and PP in these patients. If the fasting is more than 95, or the postprandial, if it is impaired fasting, that is between 95 to 110, or if it is impaired glucose between 140 to 200, then that means she is going to develop GDM, and we need to change over to insulin. Although in my practice, whatever said and done, I continue metformin in women with PCOS. I am telling you here because if they stop metformin, they do develop GDM and all other problems. So I do, but I take the written informed consent because I've come to know there have been cases of litigation. So I showed in my slide those 3 lines should always be written, and safeguard yourself first before ensuring the patient's welfare. We need to be safe.
So that means, Pikee, you're saying patients who are on metformin in the first trimester should not be given an OGTT. We should not give them a glucose load. We should just do a fasting and a postprandial triage.
Or you can do continuous glucose also, like this AGP, or you can get HbA1c. So if you are doing a fasting and PP, if she is impaired fasting, impaired glucose, HbA1c more than 6, then that means she's diabetic. It is ethically wrong to give these patients a glucose as doctor.